Sure. I have no problem taking instruction for a person that might know something a little more than me.
I think if you right click that and save background,
Ah.
and then just maybe do like LBBC background or something so we know what it is. Amy. Okay, then we go to the new place. And then, yeah. And I think maybe go to the home file menu. Or insert or design. Which one here? Let's try design. Yeah. Sort of under the background styles. Format background. Picture or text fill. Oh, go back up to the middle. Yeah, and then the third.
Okay, okay.
And then file.
Kendra, can you get the call back to me on my phone, okay?
Okay, thanks, Kevin. Bam. And I think
Excellent.
you could just close. I don't think he's saved yet. So I guess what we oh, that's interesting, but it didn't take any of our text. So let's go back over to the one we were copying.
This one here.
Hi, how are you? Good. Okay, so we're just trying to copy our welcome slide into your presentation so you can just
Oh, yeah, so just pull them both up, do cascade, and then just drag them over. You want me to do it?
Oh, really? You can do that like
Look at
that?
how fast
Okay.
it is. Well, you know, you're in addition to many of your other specialties.
Wow, I didn't know you can cascade in the new one. That's
Yeah, just
excellent.
one in the front and one at the end. They're
Sure,
bookends,
I can do
actually.
that.
Mike, this is Dr. Borges.
Hi, Ginger.
Gorgeous.
Nice to
Nice
meet
to
you.
meet
So do you have my presentation open? Yeah, right there.
This would
Okay,
be your
so
presentation here.
right, so hit view and do cascade, and then hit slide sorter, and then step back.
This one, right?
Yeah, so this one is mine.
Yes.
All right, so you've
That was
got
the
that
new
one
one. We
in,
can
and
probably-
you want the one at the end. Looks like you've
It
done.
should be in the second PowerPoint down there.
Yeah, the 108B. Yeah.
Oh, there we go.
It's the first one, actually.
So you don't. Well, we'll just do it this way. I can always delete if it's duplication, but it's there already. So we just no, it's there. So we just go like that. And no, it'll be there. Just it's just sort of weird that these things are working. We try this. Minimize. No, the whole thing goes away. That's weird.
Yeah, Jim, or sorry, Johnny. I have one up here that I have personally, has a laser pointer, and I tested on here, it works fine.
Are you in this room now?
Yes, I am. Except for the second session, I go to 111.
Yes, that's the problem. Are you gonna leave it?
I can.
Okay, I see what happened.
Yeah, it's no problem.
All right, leave a remote in here, there's a remote in the other room.
Okay,
And then you'll be here when you come back.
excellent.
All right. So we don't want to do that because you guys have a very different background, so it's not going to stay the same. Where were those slides here? 2014 for call?
The 110B,
10B. Okay, let me get rid of this one then.
or sorry, 108B. Yeah.
That's okay.
Get rid of that one.
These hours in here are killing
I
me.
So yeah, that PowerPoint there has those two slides in it.
All right. So then we just do it. Well, it's the background is different, and this is white, so it's white on white. So it did carry over. You're just not seeing it. So we do copy. And get rid of that. And then I think as long as I choose the right paste selection, it should show up. So it's funny. I have you guys in my. Actually, I guess it's my other talk.
And then what we were just doing is we're pulling the background in, but it looks like maybe your orientation is a little different than ours. Yours looks more horizontal, which I don't know if that's an issue or not. But if you go to back, yeah, and then you can pull the file in.
because it's white
Make
on
sure our
white right now.
text field, the third radio button there. And then file, sorry.
No, glad you know how to do this. There we go.
Yeah. And then close, I think, yeah.
Voila.
Do that, yeah.
I wonder why the white didn't carry over with the other one though. But
Yeah,
that
I
one
know.
did.
If you go back up to the top, maybe we could just highlight the text and put it in white at least, so it shows. Yeah, I don't know why that, it took I think the other text format, which is fine. So just.
Someone does a lot of PowerPoint. Most doctors like, how do I save this? Can you open this for me? She's going all through it.
Well, can I tell you, so the painful thing is, give a lot of talks. You sort of have a slide deck you build up over years and everything. Okay, about 2 weeks ago, I treated myself to a new computer because my poor old Dell was just like a dinosaur and it would struggle to even start depending on what it was trying to interface with. So I got one of these new fancy Dell XPSs. I love it. It's lightweight. It's delightful. One little problem. Came with Windows 8. And so I basically recreated my slides from scratch because I can't it's just so hard to do anything. Like I have all this stuff on my network and my cloud and getting it in through Windows 8, it brings it in as a download and then trying to get it out of this Adobe Reader format into PowerPoint or PDF. There's just some weird glitch I'm not managing right. But it's been everything, email. Like you have to hit send twice. It's just really bizarre. Maybe it's just me, but I really miss my Windows 7.
Now, is this the format, can we go through a few slides, because I see the orientation is more wide, it's just showing up as the way you want it to be.
We're fine.
That's exactly it. Like, if you look around and you might think, this is that.
So
Yeah, so it looks okay for pulling slides together on the fly. I just don't have as many, I have more text than I would normally have because all my pretty picture slides are.
And then, you're in the same room,
I mostly
so
talk.
11:30. So the way that somebody will introduce you.
Okay.
Jean is in the room with you here.
Okay.
So Jean will introduce you. You'll do your presentation. At the end of your presentation, you'll advance to that slide with a phone number on it. People will be fielding their questions in a text message.
Right.
So Jean will be reading.
It'll be
them,
kind of like
screening
moderator
them,
style.
and then
Okay,
she'll
but
be
I just
able
stay
to-
up here, I can use the mic.
Yep, exactly.
And this is the only mic, they don't have one of those. Well, it's such a small room, I don't even need a mic.
Okay, cool.
Just get my voice going.
Get your voice going. And they'll be web streaming this morning session. So this is being web streamed via YouTube.
So I should stay mostly here and not move around a lot.
Definitely ask the camera guy.
No, that's fine.
Yeah, I think that probably makes sense.
Okay, they might have to remind me. Da, da, da.
I mean, if you want to do a selfie dance, I think.
Check 1, 2.
People are going to appreciate that. Let's see if we have any water back there behind that podium.
I do, thank you.
Okay.
And my coffee. So I'm just going to hit the ladies' room.
All right. I'm going to go check on Dr. Huttis, see if he's here. And then I'll be back in between the break. And, sorry for that dance. Yeah, Dr. Hahn from Chicago. There was some weird fire at some weird, like, yeah.
5.
So you're on here. Now, why are you on here?
Oh, I turned that on.
Yeah, so you, right, so you're viewing them. Same thing, so you might be picking up one of these that are wrong too, so you can turn these on today, you have to wait on under volume. I mean, just for future, like if you're in the room and you're hearing someone, but turn on what your frequency is. That should, unless it's the same exact one, if it's close, they'll pick up the closer one, which will be yours. I mute them at the door. And then you mute them at the door, and then you just have to watch it until you find time to figure out. Yeah. Yeah, no pause. Stop. Stop. Burn it. Done. And then once you hit that record again, we'll make it the whole new session. And don't erase anything. We have plenty of hours on it, so more is better. Just don't delete anything.
Okay.
All right, guys, I'll talk to you. All right, I'll write it back.
All right, no problem. The fancy dancy device of the laser pointer slash slide advancer. So we're at your beginning slide, backwards, forwards, and the red line there is your laser pointer.
Great, thank you.
And if you want, just keep it off for now. And
Sure.
when you turn on, you'll see the green by the off.
After we're to turn it on. Okay, so they will be filming this.
Yes.
Okay.
Rather you speak into the microphone as much as you can.
Okay.
For the podcast.
Okay. I have no idea. I just show up and do what they ask. That's just great.
Can I hear your normal speaking level when you're presenting?
Sure. Testing. 1, 2, 3. Good morning. My name is Virginia Borges. Thank you for being here. I can get louder. I can get softer. But is this about right? Keep on going. Mary had a little lamb whose fleece was white as snow. And everywhere that Mary went, the lamb was sure to go. Okay.
Sounds good. Very nice.
everyone. Welcome again. We are going to get started. I did forget to mention in my opening remarks that this plenary is being webcast, so hopefully there are lots of people watching us from around the country, maybe around the world, and they will be able to ask questions as well. So that's why Dr. Borges is going to be standing here so the camera can project her. Before we start the program, I just want you to remember we're going to have lots of time for questions, but we're going to ask you to text your questions. So as soon as Dr. Borges finishes her presentation, we will put up the text number. You can text your questions. We'll get through as many as you can. If you're not comfortable texting, you can write your question down, and either Katie or I will walk around and pick it up. We've done this several times at other conferences, and it works really well. And we're able to get through a lot more questions that way. So I am really pleased to introduce Dr. Borges. She is a longtime friend of Living Beyond Breast Cancer. She has spoken for us at many, many, many programs. She is an associate professor of medical oncology, director of Young Women's Breast Cancer Translational Program at the University of Colorado, which is so great. And we have been out there in Colorado and done yoga with Dr. Borges. So she is going to start it off with her slides, but if things come up, remember what you want to ask, and she will be answering lots of questions, and of course is willing to hang around a little bit if people want to talk to her one-on-one. So I'm really pleased to introduce Dr. Borges.
So we'll see how I do. I tend to be a bit of a wanderer when I speak, so the idea that I will stay here and not forget and start moving off. If I do, you could all just go like that for me. But good morning, and thank you so much for being here. My assigned topic for today is discussing hormone receptor positive and HER2 positive breast cancer and what's new in these targeted therapies. Because of the way they have things split out this year with different tracks, I was asked to sort of focus a little bit more on the upfront treatment of these diseases, not what's currently available for metastatic, but the bottom line is I'm happy to take questions on anything, preferably related to breast cancer, but, have a shot. And I've structured it so that I have some slides, we'll go through those in a formal manner, but I think the majority of the benefit of these types of talks just comes from my making sure that your guys' questions are getting covered. So we won't spend all the time just looking at my slides. So this was my version of the title slide. And I actually am now the director of the breast cancer research program at the University of Colorado. So, thanks. So who am I when I'm not here? I'm a nice girl, Ginger. I actually grew up in Jersey, so it was great to get to come to the homeland. I am a wife and a mom, and I'm an animal lover, and these are my 5 children. My 2 without fur, who are the older brothers to the poor middle child boy, and then my twin baby girls. They are both a year old. And so, if I seem tired, you'll know why. And just to give a little shout out, I brought with me today some members of my program. I specialize in young women's breast cancer when I'm not here. And we have a table out in that expo session, and Emily, a wonderful young woman who works with me in this program, is here to tell you about our program. And if you are someone who was affected in the younger age range of less than 46, which is sad, I'm no longer in that age range, but you could be a part of our research, and you can stop by our table and find out what that entails. It really doesn't entail much on your part, you just have to give us your email. But anyway, that would be great if anybody's interested. So here's kind of what I thought we would cover today, just kind of a reminder as to what we know right now as to why women get breast cancer. Talk about estrogen receptor positivity and HER2 positivity, and kind of what are we thinking right now? What does that really mean in terms of these terms we throw around? What are the standard treatment options that have changed in the last couple of years? There's been some exciting new things going on. So there's stuff that for those of you who have been treated or are currently being treated for early stage breast cancer, you might want to know about. And then also discuss some of the ongoing research. And again, I'm not going to cover stuff that's in the metastatic setting too much, but I'm happy to answer questions if you guys feel that that's appropriate to what you'd like to learn here with me today. So the funny thing is whenever I ask what the #1 risk factor for getting breast cancer is, nobody hits on the obvious. It helps if you're a woman. Men do get breast cancer, but not nearly at the same rate as women, so that is the defining risk factor. So when somebody always wonders, well, why did I get breast cancer? It's the duty of your assigned gender. Age does matter. In the United States, breast cancer is dominantly, that is something diagnosed in women who have gone through menopause and are more in their mid-50s, 60s, 70s, and on up. There's about 27,000 cases each year that are diagnosed under the age of 45, which represents only about 13% of all breast cancer in the US. It doesn't look like this worldwide. Worldwide, there are countries where it's actually dominantly young women who are getting diagnosed. Some reasons for that is that in certain countries there are no older women because the mean life expectancy for women is still on the order of about 35. But also there are just different tendencies based on genetics and cultural differences that we're still trying to figure out. Definitely there's been some increasing evidence that the amount of total hormone exposure a woman has in her cumulative decades before she goes through menopause is almost like a mathematical formula to help predict the amount of risk. And so a large number of the factors that you see up here are things that contribute to that. HRT stands for hormone replacement therapy, known as estrogen or progesterone replacement, particularly for women as they go through menopause and are dealing with the symptoms of that menopause. We actually saw a dip in the incidence of breast cancer in the US after the Women's Health Initiative showed that there was no cardioprotective benefit, as was once thought, from these hormone therapies. And so a lot of women opted to stop taking these medications, and it did cause a decline. Now, whether it's appropriate or needed or indicated or a good idea for a woman to take these medicines as she goes through menopause is very individual, and she has to discuss it with her doctor. But in general, the idea that it could be used to ward off what is still the #1 killer of women in the United States, heart disease, didn't pan out. And so it does have to have a little bit more decision-making than it used to. Some things are not as controllable. When we begin our period, when we end our period, how many children we choose to have if we choose to have children, whether we do or do not successfully nurse our children. And this one's a little bit more controllable, but not easy, which is, do we gain weight as we start to lose our hormones and go through menopause, or for many of you in this room, as your doctor took away your hormones and you were pushed into menopause. A very important thing for a risk of breast cancer, particularly young women's breast cancer, is whether somebody needed to be treated for cancer at a young age. So the classic here is a girl who is treated for Hodgkin's disease as a teenager has a 25-fold increased risk of getting breast cancer 10 to 15 years later, so when she's in her early 20s and 30s, if she received radiation that included the inner fields of the breast, which is a very common thing to have happen. Same with any other type of childhood cancer that involves radiation going to the breast area. Here's a big one. That's alcohol. Doctors call it ETOH. It is known that consuming alcohol can increase a woman's risk of getting breast cancer. That has to be weighed off the health benefits that consuming alcohol has been shown to reduce cardiac disease. And in women who have had breast cancer, there is no increased risk of recurrence for consumption of alcohol afterwards, provided that woman does not have an elevated body mass index. So when these data get presented at national meetings, one of my cheeky colleagues always tends to stand up and say, but if I go for a run in the morning, can I still have my glass of wine at night? And the answer is probably yes. So again, everything has to be taken into context, but I know a lot of my patients kind of drive themselves up the wall, so to speak, worrying about some of these things afterwards. And so I figured I'd highlight that, and now you can all have a glass of wine tonight. And then we'll talk a little bit about this biggie, which are the inherited genetic mutations that can predispose somebody to getting breast cancer, or even just a family history in the absence of our being able to identify it. And then two of the biggest predictors for somebody who's likely to go on to develop breast cancer is if they have a biopsy at some point that showed precancerous lesions, things known as atypical ductal hyperplasia or lobular carcinoma in situ. So I do want to point out there are some new guidelines for anyone who has been diagnosed with breast cancer at the age of 35 or under, and this gets to the hereditary factors. Thanks to Angelina Jolie, I seldom have to explain what BRCA1 and BRCA2 is anymore. I talk about genetic testing and I go, like Angelina, and my conference with the new patient is done. I should send her a fruit basket. And these genes are tracked with particularly breast cancer at a young age of onset, but not necessarily so very young, under 50. Or if a woman is diagnosed with a triple-negative breast cancer, we even think about testing her if she was under 60. If there's a presence of a family history, that just augments our desire to want to test her because the likelihood of finding something would be higher. But what is less thought about are these less common syndromes. This is called P53, also known as the Lee-Fraumeni syndrome, after Dr. Lee and Dr. Fraumeni, who first described it. And when I was in medical school, I learned this as a syndrome of families with a tremendous amount of cancers, very weird cancers, unusual cancers. And the reality is now what we recognize is the most common cancer that can track with this gene mutation is a woman getting diagnosed under the age of 35 with breast cancer, even in the absence of a family history. And it's been quite striking since we've started routinely recommending this. There's now panels that can be offered to women at their diagnosis that include not just the traditional genes, but some of these other genes that we have to think about, and P53 is one of them. And so, for example, I've had a couple of 20-something-year-olds with breast cancer who we've diagnosed this gene, one of whom, when we started screening her family, her mom found it, and then we found an early-stage colon cancer in her mom because she went and started her screening. So it's pretty important information, and it's very subtle. These are families that you would not expect to find an inherited predisposition. Another less common one that's now recommended for the under 35 at diagnosis is P10, known as Cowden's syndrome. This tracks with young breast cancer, thyroid cancer. I've actually found it in some of my patients because after I treated them for breast cancer, they went and got thyroid cancer, and it made me go, huh? And also uterine cancer. So if somebody is diagnosed with this, we will potentially counsel them to have a hysterectomy as prevention. So this is something that's changed, and I figured while I had a captive audience, I'd let you know about it. And again, these are panels that can now be ordered by your genetic counselor or your physician who handles your genetic counseling. And it is a new recommendation for all women 35 and under at diagnosis that they have this up front. So what's the other reason why women get breast cancer in the United States? Well, sadly, there's this trend that the country has been experiencing with increasing weight. And so here's by almost 10-year increments, 1990, 1999, and 2009. And this is, if you will, sort of a heat map of obesity in the United States. White is where states have really no increase in body mass index. And the more you get to the dark red is the percentage of your population who has a body mass index over 30. So to be clear, for a 5'4" woman, that would be weighing 30 pounds overweight, so that would be about 150. So not that heavy, right? 5'4", 150. And what you see here is that as body mass index goes up above 30, the rates of both cardiovascular disease and a whole host of cancers rise, including the likelihood of dying of these diseases. And that's Colorado. So it's funny, Colorado has one of the lowest rates of cancer and women dying of their breast cancer in the US. I'd like to tell you that has to do with the doctors who take care of these women. But the reality is it probably has more to do with the fact that the women who live in Colorado take care of themselves. And as you saw in that first picture, it's a really pretty place to live with a lot of mountains to climb. So it's in general pretty easy to stay in shape in Colorado in comparison to some other parts of the world. But as you see, the majority of the East Coast, including where we are now, has a substantial part of its population that have increased their body mass index over 30. And survival is related to this, and so it's something that we have to think about carefully as we raise daughters and counsel women. And if I say the word exercise 1,000 times in the rest of my presentation, this slide tells you why. So people always ask, well, what was your type of breast cancer? Or even women will say to me, what did I have again? And so I just thought I'd run through this because the vocabulary terms that we use are changing, but there's still some historical context to how we talk about breast cancer. So there's the type of breast cancer, which means what it looks like under the microscope when the pathologist first looks at the biopsy. And these go back to the days when all we had was that pathologist looking under the microscope at that biopsy, doing a description of the pattern of the cells. So ductal is the most common, lobular is a little bit less common, and there's subtypes within those. And then, of course, cancers don't always read the textbook, so there's mixed combinations of these that we see. Inflammatory breast cancer is a subset of breast cancer that presents like an infection or an inflammation, sometimes without even a big mass in the breast. And then metaplastic is a more rare subtype of breast cancer, usually of a triple negative type, but not always. And then, as you know, once cancer gets diagnosed, there's a stage. There's actually two types of staging. There's a clinical staging and a pathologic staging. And a clinical staging is when you showed up based on your physical exam, based on imaging like a mammogram, an ultrasound, an MRI, what could the doctors find in terms of, is there a tumor and what size is that tumor? Are there lymph nodes involved? And was there any evidence that the cancer had spread to elsewhere in the body? A lot of times women will get treated with something called chemotherapy before they undergo their surgery, in which case then the pathologic stage, which is the other type of stage, will hopefully go down, right? That's the point of giving all of the treatment, is that you shrink the cancer, maybe relieve the lymph nodes of cancer within them. And so somebody who comes in and clinically maybe is up here, somewhere around a 2B to a 3B, we will hopefully downstage maybe to a 1, or even best a 0. Sometimes we get what we call a pathologic complete response, where we've seen evidence that all of the tumor in the breast or the lymph nodes have died in the face of the treatment up front. We're going to talk about that a little bit, because depending on the type of breast cancer, and I have yet to get to the type of breast cancer I mean when I say that, because we're not talking this, that may or may not matter so much. Then the other thing you hear about is then there's the grade of the cancer. And grade is just how mean the cancer cells look under the microscope. There's criteria that pathologists use to determine it, so they're all speaking the same language. And grade matters because this tracks with a lot of what I'm going to show you next. About 10 years ago, the technology allowed us to start doing enhanced gene analysis. This is cancer cases. This is a very long list of genes. And red means up and green means down. And so as you look at individual cases of cancers, what you can see is there's some patterns across these various genes that set themselves up. This was one of the first publications in 2001. There have been innumerable publications since looking at expanded numbers of genes, different subsets of genes, trying to figure out, is there one magic way that we could take a fingerprint of a woman's cancer and gain all the information we need to know about how then she should be treated and what is the likelihood that she will be cured versus have to face this disease, come back, and then how best to treat it if that does arise. But even with all of this technology, what was sort of fascinating was that these subtypes that got sorted out, and these curves are in the face of no treatment. These are very, very old cases that were in the archive that were not treated. So when you see risk of people having their cancer come back, that looks that concerning. This was before what we had now to treat these cancers. And so they came up with these terms, luminal, luminal A, luminal B, HER2 positive, and either basal or triple negative. And so if you're in this room, I'm assuming you're in this category somewhere. There's a room next door for that category. But oddly enough, even with all of this, the old markers that we've been using for a long time, estrogen receptor and progesterone receptor, around for decades now, and HER2 around since about 1998, sorted out to help us identify, I'm sorry, that's supposed to say positive, nope, that's right, that's negative, identify what are some of the categories of breast cancer and how best to then treat them based on these categories. So if you were to say, well, what's my subtype of, or what type of breast cancer do I have? It gets to be a long list, right? You could have invasive ductal carcinoma that was micropapillary type, grade 3, stage 2B, and a luminal B, or estrogen receptor positive, and HER2 new positive breast cancer. There's no t-shirts for that. So you get to decide what you want to be, right? Are you just a ductal? I had kind of garden variety breast cancer, and yeah, I had that HER2 thing. You know, but if you wonder why it seems confusing sometimes, it's because there's layers to this. So I'm going to start off with the estrogen receptor positive half of the talk. And just to remind you all, the estrogen receptor is actually a very peculiar receptor. Most people think of receptors as something sticking off the top of a cancer cell like a TV antenna, and the estrogen receptor is actually nuclear. It's all the way inside the cell, inside the nucleus. And so things have to travel into the cell, get to the nucleus, and depending on how they bind to the estrogen receptor, it can either be turned on or turned off. And just to give you emphasis on how peculiar this receptor can be, one of the first treatments ever for breast cancer outside of removing a woman's ovaries was actually high-dose estrogen. Picture the houseplant theory. You give a houseplant the right amount of water, it thrives. You overwater it, it will die due to the overwatering. And that's my way of simply understanding why high-dose estrogen could work to overwhelm this receptor and shut down the cell. But that had a lot of toxicity to it, so thankfully other drugs have been developed. And there are those that block directly at the level of estrogen, therefore they're called anti-estrogens. And a subclass of them are called SERMs, selective estrogen receptor modulators. Sounds like something the little Martian from Bugs Bunny should be carrying. But these are very common drugs like Tamoxifen. Raloxifene is used for the prevention of breast cancer or osteoporosis. That's the drug Avista. And Herceptin is one that just hasn't made it quite as far as Tamoxifen or Raloxifene in terms of figuring out where it would land in being part of treatment or prevention for breast cancer. And then there is a second class of these compounds, which is called a pure downregulator. It actually makes the estrogen receptor sort of disintegrate, and that's fulvestrant, also known as Faslodex. And this is something that is available for the treatment of metastatic breast cancer. This is for prevention of breast cancer, treatment of early stage breast cancer and metastatic breast cancer. It's been around for over 50 years. This is for prevention of breast cancer, and as I said, that one's being worked on. The aromatase inhibitors are quite a bit different. They block at the level of the body making estrogen so that there's no estrogen getting into the cells, kind of like a beaver dam effect. You block the water upstream from the estrogen receptor. And these are the aromatase inhibitors. Many of you might even be on them. We'll talk about them more. And then also it can be done in younger women by shutting down their ovaries, which is called ovarian suppression, or removing their ovaries, ovarian ablation. So all of these things can track for different ways in which we can target estrogen to treat breast cancer. So remember, when I say treat, and we're talking about early stage breast cancer, it's either being given before you go to surgery to try and shrink things down, but there's still a plan for surgery, or it's being given after surgery. And the reason for that is because even in the hands of the best surgeon on the planet, there is still the risk that some cells escaped and are hiding out beyond any level of detection in a person's body. And those are called microscopic disease. And when I say any level of detection, our scans can't show it, our blood tests can't show it, even some of the fanciest experimental blood tests that we're working on may get us there. What I really need is my Star Trek tricorder to kind of run over my patient. Beep, 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 beep. Okay, no cells. See ya. Beep, 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 cells. Yeah, okay, come here. And so we're working on blood tests and even some breath tests, and there's even maybe cats and dogs that can smell cancer in people. So I want my clinic puppy, but haven't gotten there yet, but it's coming. So hopefully by the end of my career, we'll have better than what we have right now. But for right now, we have to use based risk assessments. So years and years and years of knowledge about how likely a woman is to get a recurrence of breast cancer to then figure out, is it worth her taking this therapy? And so we can use tamoxifen to block estrogen. We can use the aromatase inhibitors, anastrozole, letrozole, and exemestane, also known as Arimidex, Femara, and Aromacin, to block the peripheral conversion of androgen to estrogen in the female body. And then we can also block at the level of shutting down the ovaries with drugs like Zoladex or Lupron. There's more, but these are injections, basically, they work at the level of the pituitary gland. So they block the hormones that the pituitary gland sends down to the ovaries, telling the ovaries to make estrogen. So when a woman who's receiving these, we see a low level of function here and a low level of function there. When a woman goes through menopause, this pathway naturally shuts down. The ovaries are no longer responsive to the pituitary gland. So conversely, in a woman who's been through menopause, we'll see these hormones go sky high because the pituitary gland is still sending the signals. It's just the ovaries are no longer listening. And so that's how we can distinguish if a woman's in menopause. The problem is if a woman's been treated for breast cancer when she was younger and she's now post her chemotherapy and maybe her ovaries aren't clearly working, if we check her levels, it's today's truth today. 2 weeks from now, they could decide to turn on and make some hormones again. So we have to be very careful when we start talking about aromatase inhibitors that these medications are really only used in a woman for whom either the ovaries are no longer there, so we don't have to worry about them, or her age would suggest definitively she's gone through menopause, which is over 50 at a minimum, maybe older than that. If a woman's young, like between 35 and 50, even if she's been without ovarian function for a while, thanks to chemo, we have to be super careful. And so we want to make sure we don't give somebody an aromatase inhibitor that can actually stimulate the ovaries to wake up. These are fertility drugs. This is how our fertility doctors help women get pregnant. So giving an aromatase inhibitor to a 48-year-old who might still have functioning ovaries could lead to a very awkward finding. Congratulations. And it's happened. So these things have to be thought about pretty cautiously. So historically, we know that tamoxifen could be given for 5 years. An aromatase inhibitor could be given first or second in partnership with tamoxifen for either 2 or 3 years to a total of 5 years. Or you can give tamoxifen for 5 years followed by an aromatase inhibitor for 10 years. And these have been standard options now for quite some time. This is data going back a decade in terms of what we can do to help women prevent recurrence of breast cancer. So why is this needed? Which drugs should a woman take? And really, for how long should we do this? And this gets into some of the newer information. What I will emphasize, and I hope you can go forth and help be the choir on this, is that when a tumor is estrogen receptor positive, those cells that might be hiding out beyond our level of detection are often dependent upon estrogen, exquisitely so. And so by blocking them, we do an enormous amount of good to both prevent distant recurrence, metastatic disease, new breast cancer on the other side, recurrence of breast cancer in the affected breast. And the real bugaboo about ER-positive breast cancer, there's no magic about the 5-year timeline. It's not like you get to year 5.5 and say, great, I don't need to worry about this. There are actually, unfortunately, more recurrences that occur from year 5 and beyond up to 15 than there are even within the first 5 years. And it's because it's a sneaky little devil. It's not a particularly fast-growing type of cancer, and these cells often aren't very well treated by chemo because they're not the big dividing type. Now, sometimes a woman will present with a higher stage of breast cancer, and even though her tumor is one of these exquisitely estrogen receptor positive cancers, we want her to take chemo. And sometimes that chemo is even given before surgery, and at the time of the surgery, we don't see that pathologic complete response. We don't see the big kapow, and it can feel disappointing. But the good news is we now know that that doesn't need to feel disappointing. A likelihood that a woman is going to survive or not recur from that cancer isn't as dependent upon whether she got that pathologic complete response or not, like it is if somebody has a triple negative breast cancer where chemo is the only weapon. And the reason for that is because we have these drugs that go in. It's a little counterintuitive that a pill could be the strongest form of treatment for that woman's cancer in the face of chemo, surgery, radiation, things that are much more overt and powerful when you're getting it, as opposed to that thing that you just have to take every night or every morning, depending on your choices. But the reality is that pill is often the most powerful form of the therapy that that woman could have. And what we've learned is that we can even extend the amount of time that a woman takes it, and we can even think about combining things. So, as I said, tamoxifen came first. It's been around for about 50 years. Tamoxifen is a failed oral contraceptive. It was first tested to be a pill, and it also is a fertility drug and helps women get pregnant. So if you are on tamoxifen and your doctor has not spoken to you about adequate contraception, there's a CVS across the street. You might want to check it out. No, I'm serious. It can happen. And so you cannot assume that tamoxifen is preventing that. In fact, it is likely not preventing it at all. And then for postmenopausal women, we've had these aromatase inhibitors for quite some time. But now what we've learned about is that we could add blocking of the ovarian function, and I'm going to talk about the SOFT and TEX trial data in a minute, and also that there have been results now for a couple of years that we can extend tamoxifen therapy for 10 years. A lot of eye rolling when I talk to my patients about this, but the history here is that there were a number of studies looking at extending tamoxifen beyond 5 years, but they weren't that big, and the follow-up wasn't that long. And there was one study done here in the United States that actually suggested there could be a detriment to continuing the tamoxifen beyond 5 years. So that's why it got locked in at the 5-year point. Probably maybe 15 years ago or 20 years ago was when that had come to pass. And we were kind of married to the idea, but there were these 2 studies out there. They were done. It was tamoxifen of 5 years versus 10 years. And they waited until they had a very long length of time of follow-up. So that's why we hadn't heard about these studies for a long time. And then they posted their results. And the results show that there is about a 3% added benefit if a woman takes tamoxifen for 10 years versus 5. Now, 3% might not sound like that much, but when you realize there's 200,000 cases of breast cancer in the US, many of them are in younger women who aren't going to be candidates for an aromatase inhibitor, and worldwide those numbers go up, 3% starts to become a significant number of lives saved by taking a medication for longer. And so certainly for a woman who is not postmenopausal at the time of her diagnosis and does not become clearly postmenopausal in the 5 years that she is on tamoxifen for an ER-positive breast cancer, it is now clearly recommended, the guidelines say, we would like you to please take it for an additional 5 years up to 10 years for that added protection. And it's not just against metastatic disease. If a woman has maintained breast tissue, she has another breast, she has had anything, basically anything short of a bilateral mastectomy, it will help prevent new breast cancers in her remaining breast tissue at a substantial rate. Now, there are some women who maybe this isn't worthwhile. If somebody had a 3-millimeter breast cancer, I'm not sure 10 years of treatment is worthwhile. But if somebody had a 3-centimeter breast cancer or a larger sized tumor with lymph nodes involved, it clearly is. So this is something that is worth discussing with one's doctor. Now, a lot of women get diagnosed premenopausal but become postmenopausal during that time. We already know from the prior studies I just showed you that that woman could take an aromatase inhibitor, and that's probably what most doctors would prefer as long as we know she's stone cold postmenopausal. And the reason for that is that tamoxifen does have some side effects. The aromatase inhibitors don't cause any secondary cancers, and they don't cause blood clots. Tamoxifen can cause uterine cancer, and it can cause blood clots, but in a woman under 50, it doesn't, not statistically. And what we have to worry about more in a younger woman is that tamoxifen does not support the bones if a woman is premenopausal. That's actually only true if a woman is postmenopausal. So there's these flip-flops about what tamoxifen does do. So if a woman is premenopausal, very, very safe for her to take tamoxifen for 5 years, even for 10 years. A lot of my young women, they want to move on and have more kids or have their families, and so we do sequencing. They take the tamoxifen for a while, they go make a baby, maybe take some more tamoxifen, make another baby, or do back-to-back, and then go back on their tamoxifen. So it's a cumulative length of time that we ask women to do this. What is on the horizon is a study that is enrolling right now through the Southwest Oncology Group that will take something that we learned from the metastatic disease setting and apply it to the early stage breast cancer, which is incorporation of this drug called Everolimus or Afinitor. Now, there's estrogen receptor, there's progesterone receptor, there's HER2. These are pathways inside cells, normal cells, as well as pathways inside breast cancer cells. Everolimus targets something called mTOR. mTOR, I think of it as the switch between life and death inside a cell. So all of the fancy pathways that we are learning to study come down and center on mTOR. And mTOR is either turned on and the cell dies, or mTOR is turned off. On and the cell lives, off and the cell dies. And so by blocking mTOR with this drug, Everolimus, we saw in the Bolero trial that was published a couple of years ago by Dr. Baselga in the New England Journal, that you could actually take tumors that had started to develop resistance to their dependency on estrogen, continue to treat that woman with hormone-based therapies, add in this drug, which is a pill, so 2 pills, And you resensitized her cancer to the need for estrogen so that now cancers would regress or die in the face of this combination. So anything that works really well in the metastatic setting and gets FDA approved, we then start figuring out how to study it in the upfront setting. So this trial is open for women who have completed their chemo, their radiation, their surgery, and are not yet on their tamoxifen or their aromatase inhibitor, but about to start taking that. There is even the possibility of being on any of the combinations of hormone therapy. So it's not like you have to be on one particular aromatase inhibitor. This study doesn't assign that treatment. That treatment is between you and your doctor. And then you are randomized to take either Everolimus or a placebo because we're trying to figure out, does this actually add to the benefit? And so it's an important study, and it'll help us figure out if this is something that should be moved forward to the early setting and be a regular part of what we incorporate. It's a very well-tolerated drug. Its main side effect is mouth sores, but we can manage that pretty effectively by reducing the dose or with mouth rinses. So the SOFT and TEXT trial just got presented this past summer. And again, these are studies that we've been waiting for the results for a long time. This was looking at if you could take premenopausal women and basically make them chemically postmenopausal by shutting down their ovaries with those injections. And there were two trials that were designed called TEXT and SOFT. And the good news is that women were doing so well. There was so few recurrences happening that the biostatisticians had to go back to the drawing board and recalculate how they were going to combine these studies so that they would get enough information to be able to get results before, you know, all of us involved in the research were dead ourselves. And so, you know, if you have to wait 15 years for the results of a study, it's not going to help anybody. So if women end up doing better than what was estimated because of improvements in care on many levels tracking in to the overall care of women with breast cancer, they had to recalculate. So in this study, the shutdown medication was called triptorelin, which is not one that we commonly use here in the US. This was given during the chemotherapy right up front. And then women were allowed to go forward with either taking out their ovaries or irradiating them if they didn't want to stay on the shots after 6 months. And then for the SOFT trial, it was dealer's choice. The doctor, the patient could decide which of the various shutdown medication injections were used. And in both studies, then women were selected or assigned to take either the aromatase inhibitor exemestane or good old-fashioned tamoxifen. And what we saw is that, again, just to emphasize, there was practically 5,000 women enrolled in this study, and the number of women who developed metastatic disease was only a few hundred. Obviously, that's terrible for them, and we want this number to be 0, but in the grand scheme of things, and this was a worldwide study. This wasn't just a US study, so you have to take into account that the care some of these women received in other countries would be different than we might choose to do here. But you can see that this is the exemestane plus ovarian shutdown arm versus the tamoxifen plus ovarian shutdown arm. And there were fewer bad things happening here. There was less breast cancer on the other side, less metastasis, and in general, this was the favorable outcome. Now, what's not included here is there is another arm of analysis forthcoming from the SOFT trial. It wasn't part of the TEXT trial, it was the SOFT alone, which is tamoxifen only, because that's the standard of care. And it's a little bit of a conundrum because several decades ago, there was a clinical study done in young women with breast cancer that looked at chemotherapy alone, chemotherapy plus one of these shutdown ovarian drugs, or chemotherapy plus the shutdown drug plus tamoxifen. So a little bit backwards, right? We would have liked it to have been chemotherapy plus tamoxifen versus chemotherapy, tamoxifen, and shutdown. And we know from that study that the use of hormonal therapy in young women with ER-positive breast cancer is very important over and above chemo. But once upon a time, we didn't do that. Once upon a time, if a woman was young and had estrogen receptor positive breast cancer, we gave her chemo and no hormones. We learned a lot, right? Today's medicine is today's truth today because it's what we know today, and if we're not doing something different and better 5 years from now, oh boy, it's scary. And so if things change, it's not that your doctors didn't know what they were doing or was wrong with what they offered you, it's because things change, and we want them to. And that's why you guys come, so you stay abreast of what's changing. So the take-home message is that if somebody opts to block their ovaries, it's a stronger combination to go forward with the exemestane than the tamoxifen. So who should do this and what are the risks? The shutdown of the ovaries puts a woman in menopause, and we're talking about 5 years of menopause for a woman who perhaps is young enough that her ovaries would wake back up again and bring back her estrogen function. And life on tamoxifen with regularly functioning ovaries is usually quite tolerable. Doesn't have a lot of the side effects that you read about on the blogs. So if somebody was higher risk, maybe stage 2, higher stage 2, stage 3, where the risk of recurrence is not trivial for her, even after chemo, that's definitely who I want to talk about these options with. And the beautiful thing about all of this is you can try it, and if the side effects are too hard, you can always go backwards and just switch over to tamoxifen. That's not a bad thing. That's not going to harm anybody. And occasionally a young woman actually tolerates the ovarian ablation quite well and still has a sex life and seems happy and is not bothered by hot flashes or lack of sleep of night. No, that's not the most common effect. I do realize that. But, you know, until you try it, you don't know how it's going to work for you. And that's the hard part, is women often don't want to try things because they read about the side effects. And where do y'all read about the side effects? My friend, Dr. Internet. And the problem with Dr. Internet is that the women who are doing great, who have no side effects, aren't on the internet. So that's always worst case scenario a lot of the times. And so it has to be taken with a grain of salt. So in summary, if a woman is pre- or perimenopausal at her diagnosis, she can take tamoxifen for 5 years, followed by tamoxifen for another 5 years, or switch over to an aromatase inhibitor if she converts to being postmenopausal. Whether ovarian ablation plus tamoxifen or exemestane should be started in all women up front versus tamoxifen is still the way to go for some women. I think we may likely get added results in December at our major breast cancer conference of the year, so stay tuned. But it is certainly something that you could do today if that's indicated by a cancer situation. Then, if you're postmenopausal, you have a lot of options. You can do tamoxifen for 2, 3, 5, or 10 years. If you do tamoxifen for anything less than 5 years, then you switch over to an aromatase inhibitor. If you do tamoxifen for 5 years, you can still switch over to an aromatase inhibitor for another 5 years. And there are 2 major randomized clinical studies right now that we are awaiting the results of that, of course, looked at an AI for 10 years versus 5 years. For right now, most of us would stop a woman's hormonal therapy at 5 years unless there was some particular situation for her where we are worried about risk and would potentially think about continuing it in the absence of that data. But the standard of care is to stop at 5 years. And so really, I mean, is it worth it to take these drugs for that long? Yeah, it is. Because, you know, a lot of you are still going to be awfully young at 10, 13, 14 years from your original diagnosis. And as much as we'd all like this to be completely behind you and for you to just be worrying about your heart disease and your 401k, you got to take that in context of what your cancer was. And so at the 5-year mark, I always revisit this with my ladies. I'm like, well, you know, what was that little cancer we had to treat you for back then, and how worth it is for you to do more? Again, if someone was stage 0 or tiny, tiny, tiny stage 1, probably not worth the added risk of side effects. But that's not where a lot of women get diagnosed, and so we have to be careful about that and make sure we're protecting them optimally. So I'm going to switch over to HER2. HER2 is a gene, as you all know. We have it in every single one of our cells. In about a quarter of all breast cancers diagnosed in the US, this gene is part of what goes wrong. There's too many of the copies of the gene inside the cell, and it leads to an abundance of the protein being expressed on the outside of the cell, and that causes the cancer to behave very aggressively. When I began my career, the drugs for this did not exist. In fact, the first woman I ever put on a clinical trial was the pivotal clinical trial that got Herceptin approved. And so I'm dating myself, but also I lived through what we had to deal with these cancers prior to modern therapy and the changes that have occurred with modern therapy. And so that modern therapy comes in a series of clinical trials. Once we saw that the drug Herceptin or trastuzumab worked against HER2-positive breast cancer in the metastatic setting, it got very rapidly pushed forward into the adjuvant treatment. And there was a large number of studies that incorporated Herceptin, all of which showed a dramatic improvement over chemotherapy alone in improving survival of this breast cancer. And the fact that they were so consistent and so dramatic was pretty poignant in breast cancer research. So once you have one good thing, you go back and make another. Herceptin is what we call a monoclonal antibody. If a drug's generic name ends in MAB, it's a monoclonal antibody. If a drug's generic name ends in IB, it's a small molecule that goes deep inside the cell and binds inside the cell. So as you see, Herceptin is a gene, and then this pathway comes all the way to the level of protein expression. So Herceptin will bind here. It'll bind to the actual HER2 sitting on the surface of the cell and shut down the pathway. There is also a drug for metastatic breast cancer called lapatinib that can get inside the cell and shut down HER2 there. But the problem is that cancer cells are so darn sneaky that even with Herceptin binding to this protein, some cancers manage to develop resistance to that. And one of the way they did that is once the protein got to the surface, it would just sort of pop off, like, the daisy. And the cancer cell would no longer be susceptible to the Herceptin. So the company that made Herceptin went back to the drawing board and came up with son of Herceptin or daughter of Herceptin that binds sort of more here. So not the part that gets flipped off into space, but the part that's then trapped in the cell membrane. And that drug is called pertuzumab or Perdita. And Perdita was approved for the treatment of advanced HER2 positive breast cancer in 2012, and then got incorporated in 2 studies where it was given in conjunction with Herceptin and chemotherapy before surgery, what we call neoadjuvant. And in the setting of cancers that are HER2 positive, particularly if they're ER negative, it does matter that we achieve a pathologic CR rate in terms of the likelihood of that woman remaining well. And that means no cancer left in the lymph nodes, no cancer left in the breast. And so that can be used as a surrogate to figure out what's going to be a super meaningful drug that should get approved on an accelerated process, rather than doing those types of studies where we have to wait 5-10 years and see the results. So Perdita was done in 2 studies up front, combo with Herceptin, combo with the chemo drug docetaxel or Taxotere. And it doubled the likelihood of achieving a pathologic CR, such that it got FDA approval on that basis. And the current guidelines from kind of the powers that be that make guidelines for how doctors should treat patients have said that these results are so powerful for the time being, you can use Perdita either before surgery, or if a woman isn't getting chemo before surgery, or she was already diagnosed and on her treatment before all these results came out, she can get it in combination with her chemotherapy after surgery. So unlike Herceptin, which we run out for a full year, right? You get your Herceptin overlapping with your chemo, overlapping with radiation, or vice versa, whatever direction you're doing this in, and Herceptin goes for a full year. The Perdita just overlaps with the chemo, and then it ends. So it's not as much of a run out. But this has been conditionally approved. We will have to await the results of those studies where Perdita was added into the treatment regimen to figure out, does it actually enhance cure rates? Does it keep more women from having their cancer recur as metastatic disease? But we are certainly very hopeful. So just when you thought you understood ER and you understood HER2, none of us really understand it as much as we'd like to. So we talk about HER2 being positive or negative, and actually it's shades of gray, and not 50, but a high number. So there's a family of receptors of which HER2 is one member. And we know that HER2 has to bind with either copies of itself or HER3 or this guy HER1 in order to have the functioning inside the cell. And we can look at HER2 in a couple of ways. We can look at it by staining the surface of these cells, and brown is positive and the absence of brown is negative. And so 0 and 3+, which is the strongest amount of brown uptake on the surface of the cells as designated by a pathologist, are pretty obvious. From the back of the room you can see there's brown here and there isn't here. But there's these shades of brown that are labeled 1+ or 2+, and this is real. There's actually a intermediate level of HER2 increase inside a cell and an intermediate level of HER2 expression on the surface of the cell that probably means something. We've always thought 3+ was what you had to be to get benefit, and that is how the studies that I showed you on that other slide were organized. But because testing is imperfect, what we realized is that when you took women who had been designated as 3+ or positive for HER2 at their local pathology lab and retested centrally to figure out how much the level of HER2 mattered, many of those women by centralized testing would only come back in this zone. But when they went back and looked at how those women fared on their treatment, they appeared to get just as much benefit from the HER2 targeted therapy as women who were full-blown 3+ positive. So now there's a couple of studies ongoing looking at targeting this intermediate level of HER2. And in Colorado, when we looked at our patient population to figure out, well, how prevalent is this? It was actually about 50% of all of our breast cancers who would have been labeled, or you would have been told you're HER2 negative, but you actually weren't HER2 zero. You were HER2 a little bit. And there's a vaccine out there that's being looked at, and there's also a cooperative group study that gives the exact same regimen that we tried in women with full-blown HER2 3+ or positive by our current definitions, the exact same regimen to see if they'll get as much benefit if they are in this intermediate zone. So stay tuned, but it's getting that complicated that there's actually probably going to be a spectrum of all of these things. And depending on where you fall on the spectrum is what your treatment assignment would likely be if you were diagnosed. And then, of course, how all of this will play out to these drugs that we use if a woman's cancer should recur also remains to be figured out. So again, like I said before, you could label yourself all of these things, and now you have the option, well, I'm ductal, stage 2B, grade 2, ER positive, HER2 negative, but actually intermediate. So why are we not done yet, right? All these years of research, why do I still have a job? I'd really rather not. I showed you those great kids. I showed you where I live, right? I could definitely occupy my time if we cured cancer. But I just want to emphasize the complexity. So there's one woman, and she'll have results for estrogen and progesterone. She'll have results for HER2. Didn't have time today, but there's this other burgeoning field of research about the androgen receptor. Oh yeah. There's a male partner to estrogen and progesterone that we're just starting to understand. It's present in a lot of cancers. We're developing drugs to target it. Don't quite yet know what it means for prognosis. Then you also saw that genomic profiling that we're capable of. That's moving forward very quickly, and it's becoming much less expensive and much more real-time, so that probably not too far into the future, if a woman gets diagnosed with breast cancer, we can run a very complex chip and figure out, okay, one from column A, one from column D for her treatment, and the next woman will need one from column B and one from column E for her treatment. And we can stop trying to lump you into these little cookie cutters of stage or very inelegant ways of looking at breast cancer to figure out appropriate treatments. We can already do that if a woman's cancer recurs. There's some very fancy testing right now to figure out additional targets. There's also the inherited gene mutations. We are now developing therapies that could work on this. There's how well or poorly the woman may choose to take care of herself. And then there's these life windows. In young women's breast cancer, I specialize in something called postpartum breast cancer, because a woman who gets diagnosed in the early years after having her children has a different risk to her cancer than a woman who has maybe a 15-year-old at home. And we don't really know what the overlay of menopause and how close into menopause a woman's risks may be. And then there's the background. What does this woman do when she's not seeing her doctor? Does she have resources? Is she able to get the level of care that we would choose? Is she compliant with what we ask her to do? What else is she doing based on what she read off the internet that doesn't make a whole lot of scientific sense, but they have much better advertising than your doctor? And does she have the right support? Is she able to take care of herself in a way that we want to because she can, versus she's just so busy she's exhausted all the time with her other requirements in life? So there's a couple of adjuvant clinical trials going on right now that I'd say, if you know women getting newly diagnosed, spread the word. In addition to the regimens that we typically use to treat HER2-positive breast cancer, and these are drugs, that's being done in premenopausal women with the idea of overlapping the ovarian suppression right up front with the chemotherapy if a woman is also estrogen receptor positive. So dual estrogen receptor positive, HER2 positive, tackling both at the exact same time right up front. Very, very logical study that needs to get done. TDM1 is a hot new drug that's been FDA approved for metastatic HER2 breast cancer. It's called Kadcyla. It's like a Trojan horse. It's Herceptin, but it has a chemotherapy linked to it. So when the Herceptin binds to the protein, the chemo actually goes inside the cell and nukes the cell, but the body itself does not experience the side effects of the chemo. Very sexy, very effective. And so that's being moved up to women who have gotten upfront chemotherapy for their HER2 breast cancer, but didn't get that pathologic complete response. We know that they are at risk, so now we're bringing in drugs from the metastatic setting to see if we can improve that. And then for women who are BRCA positive, we actually have drugs called PARP inhibitors that we think may make the therapies work better. And so same thing, upfront chemotherapy could be BRCA1 or BRCA2, and BRCA2 are usually ER positive breast cancer, so you don't have to be triple negative BRCA to meet this criteria. This study is forthcoming, and it takes women who are even several months out from the completion of their regular therapy, so definitely worth thinking about. I'm going to skip this in the interest of time, but just to let you know what's coming. Historically, we have had to do clinical studies in just a large group of women. Again, batching you maybe by age, premenopausal over here, postmenopausal over here. You guys go on that clinical study, you guys go on that one. Or maybe ER positive up front, HER2 in the back, or vice versa, triple negative, room next door. Everybody gets a clinical study. What we're getting to is the level of really making those fingerprints about cancers. It may be that drugs that we currently use to treat cancers other than breast cancer will be the right thing to pull in, because the gene that is abnormal, or the profile that is abnormal in one woman's breast cancer actually mimics an ovarian cancer or a lung cancer. So we should learn from what our colleagues know and use those types of treatments. So that's where we're moving. So the likelihood that in clinical studies coming forward, we will have more women who benefit from the treatment that is being applied is totally different than what happened 20 years ago when it was drug A plus B versus drug A plus C, and we didn't really have any predictors for who we were asking to be a part of that clinical study. So again, these are the directions of the field. That's kind of what I was just saying. And all I can encourage you guys is that life is short. If you got diagnosed with breast cancer, I hope you're doing well, whether you're living with it right now or it's hopefully behind you. And no matter what, you should always work hard and play hard. That's me being Sherpa'd up a scary ski run in Aspen by one of my colleagues. He's a medical oncologist, and the person taking the picture is a surgical oncologist. And yeah, my boys carry my skis for me. I have great colleagues. And so to ask a question, please send a text to this number, or you are also welcome to write it down if, like me, texting is a challenge that you don't readily live up to.
Thank you. All right, so we have about 15 minutes for questions, but remember, Dr. Borges will be back with us after there's time to go visit the exhibit table. So, and that part of our talk will be more about managing side effects. So we're going to start taking questions. Do you have any yet?
Write it down. Write it down.
Okay. You guys starting to text?
And I think
We
have
do
one
have a
written down.
question from the web
Okay.
that wants to know what percentage of breast cancer starts in the milk ducts, and if it's a large percentage, I think she's actually asking why wouldn't you remove the ducts before?
So the slide I showed earlier where it broke down breast cancers into classifications, that's why we call it infiltrating ductal carcinoma, because it looks like it arose in the duct. That is the overwhelming majority of breast cancer diagnosed in the US, as opposed to it beginning in the lobules. To remove just the ducts without removing the lobules from a breast would be a fairly disfiguring surgery. And so I think that's why we know bilateral mastectomies can be preventative for breast cancer. But it is something that we would reserve and encourage only women who are thought to be of particularly high risk, such as identified as carrying a gene mutation from their family, to do so as a completely prophylactic or preventative surgery. Once a woman's been diagnosed, whether she has a breast cancer inherited gene or not, it's a very personal choice for her as to what level of prevention on top of treatment for her current cancer. But it's a good question. There is research exploring the idea that maybe we could shoot something back up the duct and prevent that. Dr. Susan Love, who, I don't know if any of you have heard of her. Yeah. That's been a long avenue of her research that she's very interested in introductal therapy. So it's a great question, but we're not there yet.
So there's a question about, what can you tell us about topical tamoxifen?
Well, that would be great, right? There's one study to show that if you rubbed topical tamoxifen on the breast as opposed to swallowing the pill, it reduced ductal carcinoma in situ. So that's stage 0 non-invasive breast cancer. So there's a lot of things being explored to try and make life easier for women. I probably wouldn't be any better at remembering to rub a cream on myself than I would to take a pill, but it is possible that by doing so we would avoid some of the side effects of tamoxifen that we would rather avoid. So it's under investigation, not prime time, not for invasive disease. And I don't know if you guys know, there's also subcutaneous Herceptin. So instead of needing to get an IV, you get an injection under the skin. And I asked one of my patients once very naively, well, why would you want a shot instead of an IV? And she looked at me and she goes, you've never been to your own infusion center, have you? I was like, all right, fair point. So these things are forthcoming. They're not quite prime time now, but there's a lot of effort being made to make treatment easier for women, both logistically and side effect-wise.
So if a woman might have issues with blood clotting and she is premenopausal, so can't take tamoxifen, what would you recommend?
Ovarian ablation with exemestane, now that we have the data, if she can tolerate it. If she can't tolerate it, just the ovarian ablation. And, you know, I didn't cover this in my talk because the slides start to go on and on and on, right? But in Europe, ovarian ablation has been used in lieu of chemotherapy for decades. It's highly effective.
Okay, and then this is another side effect question. If someone is on Herceptin and it's been put on hold because of cardiotoxicity, what would you recommend?
So the overlap of Herceptin plus chemo can have an increase in the likelihood that the heart will lose its squeezing function. We call that cardiomyopathy if it actually gets to the point of symptoms. More often what we will see is that over time there might be a reduction in the percentage read by the cardiologist of the squeezing function of the heart, but there may or may not even be anything wrong with the heart. So the usual course of action is to hold the Herceptin, repeat another heart test, either an echocardiogram or something called a MUGA, in about a month's time. And if the heart function has returned or the result is reassuring that there is no heart damage, that woman can resume treatment with Herceptin and finish out her therapy. If that does not occur, then we usually hold off and don't give any more Herceptin, calling her therapy complete at the time that this problem is identified. And that's how it was done in the clinical studies that got things approved. And the use of an entire year of Herceptin may not be needed for all women. That's what was studied and that's what is the standard. But there was a study out of Finland that used less duration and saw added benefit as well. So we like to complete the full course, but if we can't, that doesn't mean the woman won't get her benefit.
Okay, so are you at higher risk for recurrence if you're ER/PR positive and under the age of 35?
In comparison to, okay, so if you are ER/PR positive, that tracks with a lower risk of recurrence in comparison to someone who is ER/PR negative. But if a woman is under the age of 35, there has been an associated increased risk of recurrence. The research I do looks specifically at young moms, and that is where we see the increased risk, is that if a woman is diagnosed with children age 5 or under at home, not pregnant at the time of her diagnosis, but a mom already, a mom with a child, as opposed to a pregnant mom. You know what I mean, right? Anyway, that's where we see the increased risk of recurrence due to that cancer for reasons that we're currently studying. And how much that also is incorporated into a young woman who is not a young mom is part of ongoing research. But age does matter. Very young women do appear to have different risks related to their breast cancer, and we're working on that.
Okay, so there's a question about bone health, and there is a workshop, I think, this afternoon on bone health, but the question has to do, if you're a young woman on hormonal therapy, can you give some suggestions about bone?
Yeah, so I don't want to steal my own thunder, because that's about like 5 slides in my next talk. But bottom line is, if a young woman is got an ER-positive breast cancer and she's on either tamoxifen or tamoxifen plus ovarian ablation, she has to have her bone density checked, which let's start there because typically young women are not getting these tests. They're reserved for women who have gone through menopause. And then depending on your bone density is what should be done. If your bone density is fantastic because you're a young woman, you should exercise, including weight-bearing exercise or yoga, things to help strengthen your bones. You should have your vitamin D level checked. You should take a vitamin D supplement at the level appropriate based on what your level was. You should probably also take some calcium, but there's reasons why we may or may not recommend that. So that's the type of thing you have to talk about with your oncologist and or your primary care doctor. But there's a lot that we can do to support bone health. If your bone density begins to decline, there are medications that can be used that can reverse that process, and those are drugs called bisphosphonates. You've probably seen some of them advertised on TV, like Abandronate or Boniva, Sally Field with the dog. Yeah, okay. So those are very effective medications. There's also IV versions and subcutaneous versions that are even stronger. There was a study done in Austria that showed that and two done in the United States, that showed that if you gave these medications to women who were either dropping your bone density or as a protective, that you clearly did prevent them from going on to develop a drop in their bone density. But overall, it's a very low number of young women who would get to the point of having significant bone density loss to the point that we would call them osteopenia or osteoporosis. Most women will have a drop, but they'll still remain in the normal range or just go slightly into the range of osteopenia, which can be reversed. So it is never a reason why a woman should not take her hormonal therapy regardless of her age. We can manage this.
So there's a bunch of questions. I know you did address this, but there's still a bunch of questions about how long people should stay on tamoxifen. So if you are if you're 40, you're ER positive, and you're still getting your periods, you've already done 5 years.
So depending on the stage of your cancer at diagnosis and what you and your doctor would discuss as your likely ongoing risk for recurrence or a new breast cancer, because again, it matters a little bit in my world. If I'm looking at a woman who had a very early stage breast cancer, stage 1 or early stage 2, but she still has breast tissue, and she'd really like to not go through this again, and she's having no complications on her tamoxifen whatsoever, or complications that she finds acceptable to live with, why wouldn't we go to 10 years? Conversely, if I have a woman who is maybe 48, 49, she's done due diligence, she's taken her tamoxifen, but she's having a lot of gynecologic side effects from it. She's having polyps, she's having dysfunctional bleeding, she's getting DNCs or ultrasounds, and she's scared. She's worried that something negative's going to happen here. Well, you could have her conclude her tamoxifen at 5 years, deal with those issues, and then if she becomes postmenopausal, take an aromatase inhibitor then. We know that there is benefit to going on to a drug like letrozole or Femara, even if you have some numbers of years of interruption from when you finished your tamoxifen to when you become postmenopausal and are then a candidate for that drug. So 5 years doesn't actually have to be the ultimate decision point. If things are going smoothly, rock on. But if they're not, you can come back. I will see my patients sometimes a couple of years after they finish their 5 years of tamoxifen because they're having these types of problems, but I want to readdress with them in a couple of years after things have settled down. Okay, how you feeling? Great, here's your prescription, let's try again.
So some people are worried now they might be getting pregnant. So is it ever possible that ovarian suppression doesn't work?
It is uncommon, but yes, there are ovaries that are out, strong like bull ovaries that can resist the effects of the ovarian suppression. Usually that woman would still cycle. So there'd be a sign that it's not working. If a woman is on ovarian suppression, she's not cycling, she's having hot flashes, it's working. If you look at the package insert for these drugs, it does not suggest they should be used for contraception. In theory, if you've made a woman postmenopausal, you're preventing her from becoming pregnant, so it's a bit of a conversation. But if they are working and a woman is postmenopausal, she should not be able to become pregnant because she's not producing follicles, she's not producing eggs, her ovaries are shut down. Tamoxifen alone is the one that we worry more about. And there's lots of ways to prevent pregnancy. That's a different lecture.
So a lot of people want to know, what does OCP stand for?
Oral contraceptives.
There we go.
The pill.
Okay.
So, and that's a tough one, right? Because there was data from the original pills that came out in the 70s that were very high estrogen, that there could be an increased risk of breast cancer. There was a series of data done more in like the 80s of 90s when it was those rotational pills where you bled every month that showed it didn't seem like they increased the risk. There's some newer data forthcoming that says that it's probably not that simple. And so one of the things that's really, and it tracks specifically with younger women's breast cancer. Again, for older women, not clear that it sorts out. But the risk of breast cancer in the United States matters based on ethnicity, skin color. Women who are under 45, there is a small majority of those younger women who are actually Black or African American who get breast cancer in the United States. And then after menopause, the incidence really changes and the risk in Caucasian women starts to go up dramatically, whereas in Black or African American women, it kind of plateaus. And if you look at who gets what type of breast cancer, there are more African American women in proportion to white women who would be in the other room talking about triple negative breast cancer. But in all women, regardless of how young you are, regardless of what your ethnic background is, the majority of breast cancer is estrogen receptor positive. It's just a matter of how much of these other types of breast cancer are there. So I hope that point was clear. The majority of breast cancer is ER positive, but if you look at who gets triple negative breast cancer, a higher proportion of those women will be African American than in an ER positive population. So, so how these things like hormones and pregnancy and nursing interacts with breast cancer matters. There's actually a publication of collaborators of mine, Julie Palmer and Christine Amberzone from Roswell Park, that just got published, showing that there is an increased risk in breast cancer in young Black mothers who don't nurse their kids. And so that's available on the internet if you want to look it up. But that is one risk factor that is specific to a proportion of our population, but not all of the population.
Okay, we'll ask one more question now. There's a lot of side effect questions, so remember, you're going to have a chance to get to your side effect. Someone's asking, is there a link between BRCA2 and thyroid cancer?
No, that's P10, Cowden syndrome.
Okay.
Now, so you can get more than one gene, right? You can get an abnormal BRCA gene from mom or dad, and you can get an abnormal other gene from mom or dad. And so genetic testing has to depend on the cancers in the individual and the cancers in the family. And so I have a young woman who got tested, she's BRCA negative, but her family syndrome suggests a different gene, so she's getting tested again for these other genes.
All right, great. So you have a half an hour to go get something to eat, visit the exhibits, and come back here, and we will hear more from Dr. Borges. Thank you.